Okay, there you go. Now, it's a little confusing because if you look that way, you're right.
It is a challenge.
It is. You gotta.
Yeah, we didn't.
Okay, we're gonna go ahead and get started again. So what we're going to do now is have a panel discussion, like we had this morning with these last two speakers. And I think as we're settling down, I think I'll start off with a question. And it's a question for Paul about what Larry said. So, you know, because both of you talked about the role of children in thinking about obligations for health care and the rationales for why there might be obligations to provide health care for children. And, you know, and Larry's discussion was very much about this idea of self-interest and why that might be compelling. Your way of describing it was more, well, it really doesn't cost that much, so we might as well just do it. That's kind of what I think I was taking from your description, and maybe I didn't quite fully understand it. But I was curious to ask you, Paul, how the way you were thinking about why there might be a slightly stronger obligation for healthcare, how that relates to what Larry said, and whether that adds to what you're saying or it's just completely at a different plane.
Well, children don't have a choice about whether to insure themselves or not. That point was made this morning. And it certainly becomes an important consideration for universal access of children to care. When I made the prevention and effectiveness and efficiency points and cost effectiveness points about most children's primary care, at least, it was in the face of the challenge that, regardless of those arguments based on opportunity and dependence of the child and only other people can provide the child with insurance, they're still the healthiest segment of the population, so why not put them in second place?
Okay.
And so they're in already for other reasons. But then, to reply to the objection that, well, we would want to sort of downgrade the priority of their care because they're the healthiest segment already, I made those other points.
Yeah, so I'm now going to ask Larry sort of a related question as I'm waiting for more people to come up to the...
By the way, I share Larry's mutual self-interest point. I mean, I think it's also a very strong reason for caring about children's health and children's insurance.
So it sounds like, though, that that approach of efficiency, given low cost, is one that doesn't work if things are expensive. So there's a lot of children who have fairly expensive costs rather than simple costs. And it seems like Larry, your approach would address that at a deeper level of saying, here's why we ought to spend for things that may be pretty expensive if it's for children.
Yeah, I guess I hadn't intended that my remarks about, you know, high technology, marginally effective interventions to really have the application directly to children. I'll have to think about that a little. I mean, you know, I generally think that the healthcare system needs to be far more efficient and cost effective. But the place that shows up is where there is guaranteed access and where there are vocal demands, where there's a highly vocal, politically active population, worried about what they're getting and so on. And this is an earlier point I was trying to make. I mean, I think really children are underserved in large part because they don't have an adequate political voice, in spite of many, of course, parents who care deeply about them. But it's not the same. And I think we need to own up to that as a society. Children are vulnerable in several kinds of dimensions, and this is one of them. Political underrepresentation And the way our political system works now, of course, has an awful lot to do with segmented interest groups and the voice that they have. I'm really sorry, actually, that Jim McDermott isn't here, because I would love to see him address that question, but maybe others of you would as well.
Okay. Over here.
This is for Larry. Brian Carter from your institution, Larry. Do you think that this phenomena, whether we are talking specifically about individual patient-focused care or the extreme that you used to talk about irrational entitlement, which is an exaggeration of individual patient-focused care, are a byproduct of the prevailing American principle, or perhaps overuse of the principle of autonomy, or autonomy gone amok, that might be circumvented in more communitarian societies? And if so, can you name one? Or can you give us pointers on how to become one?
Yeah, great. That's a great question. I mean, the short answer is yes. In terms of, I'm a firm believer, like everybody I know, in terms of autonomy, but not spreading that so thinly across the ethics map that it's supposed to cover anything and everything that we might want. We have what I think is a highly commercialized notion of autonomy in this culture, rather than what I would think is a more responsive participatory model of autonomy. We feel deprived if we can't choose between 37 different shaving creams, at the drugstore, when in fact, what the hell does it really matter? And the choices about which we ought to be focused, and many of them are in healthcare, are ones in which I think people can be situated to understand what they're choosing. So one little short snippet of something I see daily in intensive care units, where most of our business is done from the Ethics Consult Service, is with the best of intentions, physicians laying out the options for the family. We can do this, we can do this, we can do that, and so on. And we need to know what you would like, because we may get into difficulty treating your dad. Well, what can a person say? Boy, we want the best care you can possibly give. We want all those things you've talked about, when in fact the physician is hoping that the family will be saying something like, well, can you tell us more about the effectiveness of those, or is this really going to help? But what person in a crisis is going to be thinking that? So I think we unfairly, frequently, in medical crises, put families and sometimes patients too in untenable situations. I would call this a perversion of autonomy, because it seems to me medical care always has to come with a very strong recommendation about what we think is really going to be best for your dad. And in the absence of that, I just want to say that's a responsibility gone amok. It's like passing off to you a very hard choice that I don't want to have to make. But yes, the short answer is yes, and certainly some European societies have much stronger traditions of what we might call paternalism, and not all paternalism is bad, and certainly if it doesn't mean just raw coercing of choices, it means really trying to get people up to speed in terms of what the choices would mean, and not putting the choice on them. A lot of families, including my own father, was unable to make a choice to take my mother off of a feeding tube, even though she had talked to every member of the family and her physicians. She had a living will, a durable power of attorney. She did not want this after multiple strokes. My father just couldn't do it. He couldn't bring himself to say, I think you ought to take that feeding tube out, or that you shouldn't put it in. So I'm a little jaundiced, I suppose, by that kind of experience. But yes, boy, we need an autonomy ethic. We also need, a caring ethic. We need a bit more of communitarian policymaking around the way we enact the choices we give to people?
I just don't see that there's a war between collectivist and communitarian. There shouldn't be a war at all between individualist and collectivist communitarian social philosophy. I mean, yes, there's a difference between a hard libertarian philosophy and almost everything else. And there's a difference between extreme egalitarian philosophies and almost everything else. But most US individualism, I think, shares powerfully in some kind of principle about opportunity. You can call it fair opportunity, you can call it equal opportunity for well-being. And also, conservatives and liberals think it's unfair for people to gain the system, or in one particular form of it, to free ride on other people's contributions to enterprises that provide them, the people who aren't paying, some good that they don't pay their fair share for. And the society's justified in extracting fair share contributions to reduce free riding. Individualists believe that as much as liberals and egalitarians believe it. And so there's a lot more room for common ground than we typically think, not only in philosophical circles, not only in political circles, but even in philosophical circles, I think.
Yeah, Paul, I enjoyed the way you laid out the problem in your talk, and your two possible solutions you came to the conclusion might address many of those problems, one of which is a single-payer system and the other is an insurance mandate. And I agree with your analysis, but to me it brings to mind another question, and I'd actually be interested in hearing what both of you have to say about this, which is that it seems to me if you have an insurance mandate and then a very regulated insurance industry, the next logical question to ask is, what are the insurance companies actually adding to this system other than cost? In other words, there's a lot of administrative burden associated with having an insurance company between sort of the payers and healthcare delivery. And you could consider a mandate essentially a tax, it's just got a different name. And we don't have to call it a tax because we call it an insurance mandate. So what exactly do you add by putting an insurance company in the middle as opposed to, and I know there's a political reality here, which is that there's a very strong insurance lobby. But what's the value added there?
Well, insurance company profits are not a big part of the problem. Some of you would be shocked to hear anybody say that. But as a proportion of our overall healthcare expenditures, they're very small. About $40 billion out of $2.5 trillion. Inefficiency is the greater consideration. Administrative inefficiency in running a multi-payer system without common paperwork procedures is huge. Germany, though, and the Netherlands have overcome that by just saying, okay, all you multiple insurance companies, you've got to have the same procedures. Now, they even have their own boards that collectively get together that decide on it, so it isn't all just government dictated. It's the insurance companies get together and decide what common, and the government says you got to have common ones. And the savings are huge. And then they have it all automated by computerized payment. And the French go even further and have the carte vitale, where it all happens on a computer chip in a card, which is fantastically efficient. And the Germans finally woke up one day and said, my gosh, the French are more efficient than we are. That can't be. And now they've started down the same road. So in multi-payer systems, you can get around some of these otherwise terrible disadvantages of multi-payer systems. But you've got to recognize that it's a more common framework, and which we aren't there yet. I mean, PPACA has been controversial enough with its regulation of insurance companies, and there's got to be more of it to get me in the last analysis to say multi-payer system is as good as a single payer.
Okay, over here.
Yeah, I was thinking about the whole system, and then the part of the system that probably causes more moral distress than almost anything else. The issue of kind of end-of-life care that deals with really tough, futile decisions. Larry, one of the points that you were making is about autonomy, and oftentimes I'm in situations where families will say, do everything, as kind of an assertion of their autonomy, and I've always wondered if that really was a complete sentence. It seems to me we need a direct object or an indirect object in there somewhere. Do everything to accomplish what goal? And as the thing I'd like your or anybody's comment on is, it seems to me that as we think about autonomy, many of us that have done clinicians or as philosophers, we've spent years and years learning to do the treatments that we do and learning when to do those well. Expecting that a family would learn how to do that very quickly after their child gets sick is really tough. I think the thing where the family really needs to have an autonomous assertion of their right is on goal setting, not on treatment setting. Comments?
Yeah, I agree with you. I think that's a nice way to put it. We're working on an intervention currently in the adult ICUs that goes something like this, that the initial conversation you have with the family, usually not the patient who's too sick to know if they're going to survive, has to include some fundamental elements. Our ICU chief says you've got to use the word death or died in that initial conversation. And he's even more blunt. He said, if you don't see them cry, you don't know that they've heard you. So we call it the make them cry rule. But another issue has to do with an explanation that everything we do in ICUs is a time-limited trial. This is not a permanent state of life. This is something we're going to try for a while and see if it helps. And here's how we'll know if it doesn't. Here's what we'll be looking for. And in 5 days, we'll know if the respirator is any good or not. And if it's not, we're going to be talking to you about taking that away and so on. So that's really important. But your really lovely point about setting goals, I think has an awful lot to do with this question about do we actually know where this patient and family come from? Is this a truck driver, who came in from a motor vehicle accident, an 18-wheeler, or is this a guy who's been transferred in, who's been retired for 10 years, and so on. And the question about, if this person could talk to us now, what would they say? And tell us about what you're thinking. Tell us about the shared portion of this. I'm very impressed with the way in which the shared dimension of this own goal setting actually can be profound in terms of its effect for preparing people for what's coming.
Yeah, it seems to me that taking on the whole system and all of healthcare for kids is something we need to work on. That may take a while. Dealing with this other issue is one that's pervasive across the health system and really would be, I think, more amenable to maybe a quicker solution.
There's a comment. Question over here. Go ahead.
Yeah, Melody Cunningham again. Something that has struck me through this, and I think it speaks a little bit to my RVU versus, you can determine 95% of diagnoses with a good history and physical, comes back to time and continuity. And I think of that with your family situation. I think we've lost continuity. I do palliative care, get called in, and you probably do when things are already contentious. And I very often find that the reason that things are contentious is that the ICU doc has switched at least every week, if not more frequently. They don't know the family. They don't know the previous discussions that have been engaged in with the family. And so they have no idea of what those goals are, and sort of, developing that relationship and that conversation with the family that comes to a consensual decision about what to do. And I think if that person had continuity with your family, that person could say, your wife, your mother would not want this. I've talked to her. We need to end this. This taking out the feeding tube is what she told me she would want. And so this is what we're going to do. And it takes the burden of the responsibility off of the family members, but it's truly was her decision that she was then, that someone postponed.
Yeah, I appreciate your point very much. In the case I mentioned with my own family, actually, it was the primary care doctor who was really advocating for the feeding tube. And, I have never forgiven him for that, actually, because I thought this was a tremendous disservice, rather than, as you say, going on the background in history. But your point is an excellent one.
And I think, one more, sorry. I think we have an obligation to tell people what the options are in the context of also making a recommendation and saying that just because we can do things doesn't mean that we should do it or that you have to do it or that it would be the best, because the best isn't always doing quote unquote everything, and kind of reframing some of those definitions. Anyway.
Joel?
Larry, one of the things you talked about was the notion that somebody might, in effect, bite us back if we don't treat them fairly to begin with, and depriving children of certain entitlements or whatever may come back to bite us later when they're grown-ups and making decisions. I'm wondering whether you could say some more about what our approach to that should be. Just to be more concrete, it's often in the case where I'm either the ethics consultant or the palliative care doctor, and I'm talking with a family in the newborn intensive care unit, and the family says, well, if this were a white child, we're sure you would do this. Their goal is for us to do two things. One is extend their child's life as long as possible, and second, treat the child as if it were a white child. What do you think we should be doing about this on an institutional level, a social level?
Well, that's very hard, but my experience is just like yours. And honestly, I don't know in terms of preventing the immediate problem, but I am convinced that those kind of demands come from larger social forces which have to do with the history of discrimination, of deprivation, of not having your needs met, of having to beg for what you get. A whole series of things, the upstream drivers. I would be suspicious too if this had been the case for me with regard to how difficult it was to get some of my fundamental needs met in medical care. So, I don't have a good answer for you, Joel. It just seems to me that, boy, this ought to be a project we're working on, and especially if we recognize social determinants as, okay, not only having a profound effect on health status and life possibilities, but also on the extent to which I can participate meaningfully in the health care I do get.
Okay, one more question over here.
Thank you. Yes, I'm Tim Haynes here with the National Association of Children's Hospitals. And I'd like to thank Larry, you, and many of the other presenters today on setting up this understanding of care with obviously end-of-life care being the most expensive part of care, and with healthcare being a finite resource, and end-of-life care being so difficult. Just a broader philosophical question in a culture with so many different religions, cultures, backgrounds that we're treating. Historically, dying well has been done in the context of a culture or a faith. As medical providers, we're serving all of these broad parts of the population, yet to change end-of-life care will involve some kind of change of culture. How do both of y'all, and anyone else who wishes to comment, see how we can inform culture so that we can die well? I thought I'd make it easy for you, since it's the last question.
Well, it's such a basic part of life and culture that it becomes everyone's responsibility to think about and contribute to this, from pastors, to parents, to trusted friends, to one's own children, perhaps provoking a parent a bit, wanting to know what they will want done. Times come to, obviously, physicians, nurses. We are a death-denying society. David Brooks, I think, was right about this in the New York Times a week ago. And it's a very challenging corner we've gotten ourselves into. We're both a highly technological society and we're a death-denying society. And we took death away from people when we, in the last 60 years, have put almost everybody into a hospital to die. So we don't see animals die on the farm as much anymore. I mean, there's just it's such a huge challenge in our society. I tell my students, just start talking about death. Ask your parents whether they're afraid of it. And frankly, you know, after spring break, my students come back and they say, we had the best dinner table conversations. I mean, people really do, they're denying it, but they know we all die. And before they get in corners, they're willing, when provoked a bit, just gently even nudged. They're willing to talk about it. We all have to do our part on this.
I don't know, give you the last word. Go ahead.
Okay, just a quick response. As a graduate student, I studied comparative religion for a chunk of it. That was about 200 years ago, so this may be dated, but I don't know of any major religious tradition in which there is an obligation to prolong your life as long as possible. It's always with the caveat you should live as long as you should, not as long as you can, and it's in the service of a larger sense about finitude and so on. Now, that isn't to say that, boy, we are so religiously pluralistic, and you know, if you add religion and spirituality as major traditions in this country, you're going to run into everything. So I'm not saying there aren't people who have deep spiritual convictions about the fact that they are owed, you know, a long and happy life. But just one little addition, and that is, I think Paul is absolutely right about this. We can talk about it, and it's always better to talk about it before the crisis. But I think it's also really important to give people a realistic sense about what we can do, so that sometimes people will not choose when they fully understand the implications of what their life may look like post-intervention. So there's some kind of a test of realism that it seems to me we have to begin to ask people to pass in relation to this question.
Okay, well, I want to thank both of our panelists. Thank you very much.